was down, but now I'm up. Yeah.
All right, welcome to the EG Dominates podcast, coming to you today from Orlando, Florida. And my guest is a very special guest today. I'm joined today by Dr. Terry Sue from Florida Maxillofacial and Reconstructive Surgery. And so excited to have you on the show. So many people that I've come across in the last 12 months that said, man, who is this doctor that was so impactful in helping to save your life? And I'm just so grateful for you and the opportunity that we have to sit down and have my audience kind of get a better understanding of who you are and what your clinical expertise is. So welcome to the show.
Thank you, Eric. Thanks for having me on.
Absolutely. So I found you through connections that I have in working in the dental industry for 10 years. But previous to me getting oral cancer really wasn't anything that was ever on my radar, especially being a non-smoker. I rarely ever saw or heard of dentists or hygienists doing head and neck cancer exams. So this whole experience has really kind of opened my eyes to a different part of dentistry, and I have a big respect for everything that you do. What I wanted to do was today to give the audience a chance to get to know who you are as a person, where you're from, where you grew up, the type of work that you do, how long you've been practicing here in Orlando. So with that said, take us back to where it all started for you.
So Eric, yeah, my name is Dr. Terry Sue, and I went to dental school at NYU in New York City, and did not know anything or didn't know too much about oral cancer. I really didn't know what I wanted to do after dental school. I went after I finished. After I graduated from NYU, I went back to the San Francisco Bay Area, which is where I'm from, and got my California dental license and practiced dentistry for about 8 months before I realized I really did not like dentistry. From there, I started researching into other specialties that I might be interested in, and one of the things I was really interested in was oral surgery or oral maxillofacial surgery.
Okay.
And because I had not focused my interest in oral surgery when I was in dental school, I really needed to get some experience before I could really apply for a residency program.
Mm-hmm.
And so I looked into different 1-year oral maxillofacial surgery internships that were available throughout the country, and the program I ended up choosing was the program at the University of Maryland in Baltimore.
What was it about that program that drew you in?
At the time, I really didn't, it wasn't anything. I just wanted to do the traditional bread and butter oral surgery.
Okay.
Procedures like dental implants, taking out wisdom teeth. But little did I know that program, the chairman, Dr. Robert Ord, at that time, was a oral maxillofacial surgeon who focused only on head and neck cancer,
okay,
and more specifically oral cancer. So that was really what opened my eyes to what oral maxillofacial surgeons could do.
What year was this, Dr. Sue?
This was 2003 to 2004.
Okay.
So we do, for residency training, it always starts on July 1st and it ends on June 30th the following year.
Okay.
So when I was there, I remember being in the operating room. It was an oral cancer case, and they were doing reconstruction of the tongue. It was a large cancer of the tongue. The patient had about half of the tongue removed because of the cancer, and they were doing the reconstruction with what they call a radioform free flap, which is it's a flap that's taken from the underside of the wrist. You're taking the skin and you're also taking the fascia, but you also need to take the artery and the vein, and you hook it up under a microscope to an artery and a vein in the neck, because you need to provide blood supply to this flap, and this is what you typically use to reconstruct the tongue. And I remember at the time they were harvesting the flap from the arm and seeing all this, and I was thinking to myself, this is so far removed from dentistry.
Yeah.
But that's what really got me interested in cancer and head and neck cancer.
Okay.
And so with that, I had more of a focus there. That for sure, no, the first thing was I knew then and there that I wanted to go into oral maxillofacial surgery as a specialty, but more specifically, I wanted to do head and neck cancer and reconstruction.
Okay.
So the following year, I started. I went back to California and started my applications for the different programs, and I ended up being accepted at the University of California, San Francisco oral maxillofacial surgery program, which was good for me because my program director there, by the name of Dr. Brian Schmidt, was also a head and neck cancer surgeon.
Okay.
And so that solidified my interest or my desire in wanting to pursue head and neck cancer.
Okay.
So after I completed my residency training and medical school at UCSF, I got into a fellowship in Jacksonville, Florida. It's part of the University of Florida at Jacksonville program. And for 1 year after residency, I had the training for head and neck cancer and also for the microvascular reconstruction.
And what year was this?
This was 2011 to 2012.
Now, at the time, was there a doctor up there named Rui Fernandez?
Yes.
That okay? So
Yeah.
that's who I had heard of him
Right.
through some doctors that I work with.
Right.
And then
Right. He was my mentor,
yeah.
my fellowship mentor. But I've known Rui since the time that I was the year that I was in Maryland, because he was Dr. Ord's fellow when I was the intern there.
Okay.
That year, between 2003 and 2004.
Okay.
Yeah.
Wow. So you go through the program in Jacksonville, you get them there. How did you? So was Orlando just the next stop in your journey? Because you've been all over the place in a sense.
Right.
How did you guys end up in Orlando, and how long have you been here?
I ended up in Orlando. Well, typically after when you pursue a career in head and neck cancer, usually you need to be in an academic program for the support. And so initially I looked at some job positions. I looked into LSU in New Orleans, and I forgot, there was some other program. But there weren't that many available. There weren't that many programs at the time that were really wanting to start a head and neck cancer program.
Mm-hmm.
So I basically, out of necessity, I ended up in Orlando because it was a job position available. I previously worked for HCA, which is the company is called Hospital Corporation of America, and they're the largest hospital corporation in the country. I believe they have over 160 hospitals throughout the country, and they were in the process of opening up level 2 trauma centers, and one of the locations that they wanted to open a level 2 trauma program was at the time it was called Osceola Regional Medical Center in Kissimmee. And so they hired a bunch of different specialists to help them to help support their trauma program. And they basically gave us the free range as to what we want to develop our practice to be. And I told them I had an interest in head and neck cancer, and so they were receptive to this, and so that's how I ended up in Orlando, or the Orlando area.
And that was what year?
This was, I moved down to Orlando in 2012,
Okay.
but it probably took another 8 months of contract negotiations. So I didn't start until 2013.
Okay. So one of the things I think there's a lot of things that I don't necessarily know. Myself coming from the world of medical device sales in the hospital and then switching over to dentistry, a little more than 10 years ago. The hospital that you actually did my surgery at, Osceola Regional, is a hospital I actually worked out of a little bit with some doctors a long, long time ago. But I was always under the impression, and I think that the norm typically is doctors usually fall within one hospital system. I don't think you typically see a lot of doctors that have privileges at multiple different hospitals or hospital systems. Tell us about what you have, because I think you're a little bit unique and rare in that sense, right?
Yeah, I think I'm very unique in the sense that we don't accept any dental insurance in my practice. We only take medical insurance, and with medical insurance, we take pretty much all medical insurance. So my practice is basically hospital-based practice. I don't do the traditional implant placements or the wisdom teeth extractions in the office. I don't do sedations in the office. The only things I will do in the office is just simple biopsies under local anesthesia, and everything else I take to the operating room. I also provide oral maxillofacial surgery emergency coverage for trauma, for facial trauma, and for infections. And because of this, I have privileges at HCA Hospital, specifically Osceola. Well, now they changed it. Now they're called HCA Florida Osceola Hospital.
Okay.
And I also have privileges at Orlando Health, because I also take call for their level 1 trauma center at Orlando Regional Medical Center. So I go back and forth between Orlando Health and HCA.
So what does a typical week look like for you?
A typical week. So Wednesdays and Thursdays are my clinic days. That's where I see new patients for consultations. I also see my follow-up patients from the hospitals. I am on call every single day. And then this is for HCA. I am on call for them every single day. And then for Orlando Health, I am on call for them for 10 days a month for a facial trauma call. So typically, I could be in the operating room Fridays, Saturdays, and even Sundays. So just for example, this past Friday I had 2 surgeries at Dr. Phillips, which is also a Orlando Health hospital. Yesterday I had 2 cases at Osceola Hospital, and then later today I have 2 more cases that are waiting for me at Osceola Hospital. So I could be operating almost any other day that I'm not in the office here.
Mm-hmm. What do you enjoy doing most? What are you most passionate about when you think about your career?
I really like to be able to help people in the sense that to help reconstruct their face, and also to treat their cancer. What I'm most proud of is being able to see some patients that I have that are 4.5, 5 years out from their cancer surgeries. And that is the greatest feeling, because over the course of the years that I've spent, not just doing their initial surgery to treat the cancer, but also to follow up with them for cancer surveillance.
I'll be with you for a couple more years, right?
Exactly.
Yeah.
Exactly. And you develop this bond with your patients that's very meaningful to me.
Mm-hmm. I mean, this is one of those things, Dr. Sue, where in telling this story, several times a day, forever, I never in a million years would have ever imagined that I would have been somebody that would have gotten oral cancer. To be 44 years old,
Right.
healthy, never had surgery before.
Right.
I tell people that if I wasn't in the dental industry, I don't think I would have had my lesion looked at as soon as I did, because I was right at the 3-week mark. And I'm really lucky in the sense that my path was a little bit different. I was expedited to Dr. Shonda Kelly. She did the biopsy. She's the one that called me with the results. She, I think, had already reached out to you guys in advance ahead of that. So I had my appointment, already lined up before I even had my results back from the biopsy. In hearing other survivors' stories and hearing other people that are battling oral cancer, the one distinct difference that I've picked up on is where you go first after that biopsy seems to really set the tone for what the next couple months is going to look like. I think that historically or typically people will start out in oncology first. If I'm wrong, I know this kind of correct me, but it's my understanding that you go to oncology first. They're going to run their tests. They're going to kind of quarterback what your different options are. Is that?
It could go either way.
Okay.
If the patient gets referred to me before they go and see an oncologist, that would be fine too. And I usually will just also refer them to an oncologist if they don't have one already.
Mm-hmm.
And it's not just because a lot of times, like in your case, your cancer was still an early stage cancer.
Mm-hmm.
So you didn't need any of the adjuvant treatment like radiation or radiation and chemo.
Mm-hmm.
But it's always good to also have an oncologist because especially like I am in private practice, it's good to have different people within the same field.
Yeah.
To be able to come together to come up with a consensus treatment and agree upon that what the treatment that we're providing for you is the best and it is the standard of care.
Mm-hmm. Do you feel like in the time you've been practicing here in Orlando, do you feel like you're seeing a lot more people that are getting diagnosed with some type of head and neck cancer, or do you feel like it's been pretty consistent over the last 10 to 15 years?
I think it's been pretty consistent.
Okay.
The only difference now, and I've seen this since 10 years ago, over 10 years ago since I started practicing, is that we're seeing increased prevalence of people with oral cancers who do not have the traditional risk factors like smoking and drinking.
Mm-hmm.
That is on the rise, or has been. But other than that, it's been about the same. I think it's been pretty steady since.
How do you, as a doctor, being, again, like, until something like this happens to you, you hear stories about people that go through situations and they're like, man, I feel for that person, that's tough. But until you're actually the person that it's happening to, it's extremely scary. It's the first time in my life that I've ever been faced with the reality of honestly thinking about death and dying.
Sure.
And to be this young and to have 3 children young, and you hear the story, all the time people talk about there's graveyards full of people that thought they had more time. And so I really feel like being able to take this experience and the platform and the following that I have in dental and to be able to shed light and to help not only educate people on the risk factors of oral cancer, but have amazing people like yourself on the show to kind of talk about what you see and what you hear. Doc, from an emotional standpoint, how hard is it for you, or how hard was it for you to get a customer used to having to deal with, obviously, the clinical side of things, but having to deal with the human side? I think back to when I had my first consult with you here, the first time I met you. I probably hit it pretty well, but I was scared for my life. And I didn't let myself Google or do any research prior to seeing you. So honestly, I had no idea what I was in store for. And I think that most people that get head and neck cancer don't know what they're in store for, what the options are. How have you kind of learned to combat or to deal with that emotional aspect with people?
For me, I think the most important thing is you have to give patients hope and let them know, like, because when they get referred to me and when I'm seeing them, I need to let them know. I'm honest with everyone, but you have to give them hope to let them know that it is treatable, and it is curable, but it's not an easy road, as you can you have experience, right?
Yeah.
There's a surgery, and then there's a recovery from surgery. But if it's a more advanced stage cancer, and you have to go through chemo radiation, I mean that'll take a bigger toll on you.
Mm-hmm.
But the important thing is, in a way, you still have to scare the patients a little bit, just so that they'll take it seriously and know that even though it is curable, it's very treatable, but it's just it's not an easy road.
Yeah. No, it's not. It's not an easy. You have to really mentally prepare yourself, or whoever your caregiver is. They have to mentally prepare themselves too, because it is a long road, and some days are good and upbeat and happy, but some days are tough from an emotional standpoint. So, going through that firsthand, I think about you a lot, because I think, man, all the patients that Dr. Sue has treated, that he's now seeing, on a regular basis, he's having to deal with, how many different Erics per week, right? It's probably a lot, and it takes an emotional toll on you as a doctor. Well, the time we have left, and everything that you're doing from a head and neck standpoint, the surgery, the procedure that I had, that you performed on me, a lot of people ask me about that. And they say, well, man, this doctor must have had like a team of doctors working with him. And I said, no. And this is before, I had several people that I know spoke your name before I even met you. So by the grace of God is how I got connected to you so quickly. And I think back now on, the whole situation, and time is of the essence, obviously, number one. But number two, the thing that comes up a lot is, how did this one doctor do all of this by himself? And I said, well, this is really two procedures in one. This was like an 8 to 10 hour surgery.
Right.
But you did what's called a mandibular resection,
Right.
and a neck dissection.
Correct.
How do you explain that to somebody?
So the mandibulectomy, which is what you had, was what we call a marginal mandibulectomy, meaning I just removed the top portion, the top half of your mandible or your lower jaw, and I didn't take the whole segment or section of it out.
Mm-hmm.
And the reason I had to do that was because when we remove cancer, and this is not just head and neck, this is for any cancer surgeons anywhere in the body, you can't just remove the cancer that you could see or feel. You actually have to take what we call a margin of normal tissue, where you think that that the cancer is not there. And for head and neck, usually a margin of 1 to 1.5 centimeters in all directions is required to really safely remove all the cancer. Of
Mm-hmm.
course, these cancers are cells, and when I operate, I only have magnification from my surgical loops. I do not have a microscope, so I can't tell, and sometimes the final specimen might show that the cancer is closer to the edge, or maybe is involved in the edge. But normally we do take 1 centimeter to 1.5 centimeters to ensure that we can safely, for the most part, take out all the cancer.
Mm-hmm.
So that was what that marginal mandibulectomy was for. The reason we do the neck dissection is because we know with head and neck cancers, the most common type of cancer is called squamous cell carcinoma, which is what you have, and that makes up 90% of head and neck cancers. Squamous cell carcinoma in the mouth or the oral cavity typically spreads through the lymph nodes or the lymphatic system. And even if before surgery, on CT scan, on PET scan, and on clinical examination, we don't feel any enlarged lymph node or see anything on CT scan that's suspicious for a cancer that's spread down into the lymph node, we know there's still up to a 25% chance that a cancer could have slipped into one of the lymph nodes, because again, these are cells, and usually need a tumor mass of at least a centimeter before it'll light up on CT light up on PET scan, or you could see it on CT scan. And 25%, I mean, that's like if you flip a quarter, right? Flip a coin 4 times, like say one out of 4 times, it could be in the neck. And because that incidence is high enough, that is the reason why the standard of care is to go ahead and do what we call a selective neck dissection, which is removing the lymph nodes in the areas of the neck where we know has the highest chance of where the cancer could potentially metastasize from the different areas of the oral cavity.
Man, it's a lot. It's one of those things where, when you look at all the different types of cancers out there that you can get, and kind of reading on the statistics when it comes to oral cancer, the suicide rate for oral cancer is, I think, close to 3 times that of the general population. And the reason why is because even though you're able to surgically remove the cancer, to your point, you're still going to look a little bit. I look fantastic. I mean,
absolutely.
Yeah. I told my wife, joking around, I said, "Hey, you better watch out. Now that I have teeth, I could be out there on the I'm joking. But it's one of those things where, I've learned to make this the new normal. This is who I am. And that's okay. Because I have function, I have stability, I have quality of life, and most importantly, I'm cancer-free. So if you were to speak to somebody that just found out that they were diagnosed with head and neck cancer, what is your message for them? And also, actually, what would your message be for somebody watching this that doesn't have head and neck cancer? That's maybe in the dental industry, that is seeing this, that is maybe a lot like me, that's like, man, top 10 killer, but I don't know anyone that's ever gotten oral cancer, and it's kind of out of sight, out of mind. What do you say to that?
I think everybody should be getting screened for oral cancer at least twice a year, and the recommendation is every 6 months. And for this reason, I always recommend to everybody, go see your dentist at least once every 6 months. And your dentist should not just be checking to see if you need any fillings, crowns, but they should really be feeling your neck and then also looking at your mouth. It takes no more than a minute or 2.
Mm-hmm.
And
almost like a handshake.
Exactly.
And a dental handshake.
And I know, because I remember from dental school, they taught us how to do, what we call like extra oral exam when you're feeling the neck for any enlarged lymph nodes, and then looking in the mouth carefully. And every dentist should be doing this for their patients, whether it's the dentist or the dental hygienist. It really doesn't matter.
Yeah.
As long as somebody's looking, and especially being in the dental field also, it would be a shame for a patient to end up with a large stage 3 or stage 4 cancer, because this is something that, if you miss something that's like a centimeter is still like what we call a T1 or stage 1 cancer. For someone to miss a 1 centimeter lesion, I mean, you really got to be blind if you can't see that. Yeah. And so that's why it is so important to screen patients. And my message to dentists would be, when in doubt, just send them to me. I mean, it's always better to be safe than sorry, sure. Right? And if patients come to me, they'll say like, yeah, my dentist sent me because there's like this white patch or something that he or she said that it should be looked at, and I'll say, if I don't know what it is, then I'm just gonna biopsy, because couldn't always have the pathologist look at it under the microscope. Just let us know if this is something benign, or is it something that's bad, and just we gotta do something about it.
So you have quite a few doctors that will refer patients to you. If somebody maybe doesn't have a referral, right? But they suspect that there's something going on at their mouth, that something is going to be more so that a dentist possibly is going to be able to take a look at or to handle. Are people allowed to find you on your website and to reach out to you that way, or what's kind of the proper protocol for somebody that wants to get in touch with you?
Usually, they can always call my office number.
Okay.
But I get a lot from just like the dentist will contact me, or they'll ask somebody who then knows me. The other things I do treat a lot is benign, we call benign pathology. So there's a lot of like jaw cysts or jaw tumors that some can be really, really aggressive. But these are, again, benign. But I will treat these because some of these benign jaw tumors, you essentially need to like treat it like a cancer treatment, like in terms of like resecting the portions of the jaw and then also doing the reconstruction.
Mm-hmm.
What's really fun about the reconstruction nowadays, and this has been for about the past 8 years or so, is they can do a lot of custom implants now that we weren't able to do before, and it's helped restore form and function a lot better than before. And this is the exciting part of the reconstructive surgery that we have available to us now.
Technology kind of advanced so much over the last couple of years. It's been allowed you to kind of be able to customize certain treatment approaches. Are you speaking more specifically about like a subperiosteal?
Subperiosteals, and I think also the one company called Restore 3D.
Mm-hmm.
I've seen they also have another implant that's like a complex reconstruction, where if you take out a whole segment of the mandible or the lower jaw, you can replace it with this implant that essentially looks like the mandible.
Mm-hmm.
And then you also this implant has the attachment so that you can attach the dental appliance or the dental restoration on top of it.
Yeah. It's the ability to custom 3D print, the ability to use the technology that they have nowadays to treatment plan has been absolutely fantastic. So you're even seeing this on your level in the hospital setting of how the technology is really kind of shifting and making the things that you're doing better, more impactful, probably quicker as well too. So last question for you, because I know you got to get running. When you're not at work, so you work a lot. You said it yourself when we started out. You're on call, doing a lot of things. What do you enjoy doing when you're not working?
I like to just go home and spend time with my family.
Mm-hmm.
Especially one of the things I really look forward to, and I'm glad I'm able to do this. Whenever I have time in the mornings, I tell my wife I like to just take the kids to school, drop them off to school before I go to the hospital or go to the office. And it's very important. My family is the most important thing in my life. Being able to watch my kids grow up, because they grow so fast, and next thing you know, where did the time go?
Yeah.
But that's what I enjoy. I'm on call every day, but I do take time off. We'll go on vacation like maybe 3-4 times a year.
Mm-hmm.
And that's what I really cherish is those, I work hard for those vacations so I could spend time with my family.
That's fantastic. My dad did the same thing. And it's something that me now being an adult and having kids, I'm trying to emulate and replicate those experiences that my parents brought to the table for me when I was growing up. So really, really cool to hear you do those things. It's awesome. Well, look, Dr. Su, I'm so glad that we had a chance to sit down and so glad that you had a chance to kind of shed some light on yourself and your practice in oral cancer. And you're a big part of my life. You always will be. And I'm glad to know you. Thank you so much. Thanks for being on the show.
Thanks for having me.
I was down, but now I'm up. Yeah.